And we are going to move right into our second keynote speaker this morning, and after that there will be a break. So, our second speaker is Dr. Louise Potvin. She is currently professor at the Department of Social and Preventative Medicine at the School of Public Health at the University of Montréal. She holds the Canada Research Chair in Community Approaches and Health Inequalities, which aims at documenting how public health interventions in support to local social development contribute to the reduction of health inequalities in urban settings. Her main research interests are population health, intervention research, and the role of social environments in the local production of health. She was a member of the WHO Euro Working Group on the Evaluation of Health Promotion. And in addition to having edited and co-edited 8 books, she's published more than 250 peer-reviewed papers, book chapters, editorials, and comments. She's a fellow and a director of the Canadian Academy of Health Sciences and the scientific editor of the Canadian Journal of Public Health. Please join me in welcoming Dr. Louise Potvin.
First off, the accent is French. So don't turn off the radio. And thank you very much for inviting me to discuss a little bit about our work. And well, we had a little conversation with Leora, the organizer I was in touch with, about the word invention. And she said, "Are you really discussing invention?" And especially, you know, with a group of urban planners and people whose work is to plan, I found it more interesting to discuss about how people invent their solution locally outside of a room like that, and how we, in those kind of rooms, should or could take advantage of what they're doing. How does that work? Work this way? So I have a few premises. One comes from that book from Edward Socio. And essentially, the message in that book is that human geographies are not merely external container, given and immutable. Their changeability is crucial, for it makes our geographies the target for social and political action. And that's, at the end of the day, what we're about to discuss today. Another premise comes from the first 10 years of the chair that I've been leading in the Montreal area in partnership with the Montreal Public Health Directorate. And essentially what we found throughout those years that health is created daily and in the daily life using resources available locally. So what you see in the urban environment that we're providing for ourselves, we should be thinking about it in terms of resources that people can use to make their life healthier. And essentially, locally, people invent solutions to mitigate resource deficiencies because resources are unequal. An individual limitation in order to maximize the exploitation of those resources. And these inventions engage multiple actors socially situated. What we've done in our work for the past 15 years now is to follow those people in their daily life as they create and as they invent new ways of living together to mitigate those social inequalities. Another premise is this idea that when we do research about what people do, we can learn. And essentially the epistemic relationship that we've been developing with our research subject is, and that's what we're telling them on a daily basis, we're not here to tell you what to do, we're here to tell you what you do. So we place this research apparatus as a witness and as a reflexive, as a kind of a mirror, so people can navigate those inventions with better intelligence. And finally, one another premise is this idea that evaluation and this idea of telling people what they do is actually bringing research into a political space. And getting outside of this ivory tower for academe is often finding that knowledge is just one other resource that people use to create and invent a better environment for themselves. So this is what I'm going to be talking about today. Essentially, what kind of lessons we've learned observing local inventions to mitigate the social inequalities that are ingrained in our daily environment. So, social health inequalities in Montreal, this has been a long time priority. In 1998, 10 years before the WHO, the Montreal Public Health Director created a report which was entitled Social Inequalities in Health, and in which he made it clear that social inequalities in health was the #1 priority of his organization. And 10 years later, he tried to reflect on what has been achieved. So how can we see social inequality, health inequalities in Montreal? This is the island of Montreal. In yellow, and these are CSSS, which is the Basic Health Division in Montreal. There are 29 of them. So in yellow, you have the territories in which the health expectancy is at par with the regional health expectancy. In green, where it is significantly higher, and in red, where it is significantly lower. And what you can see in there is between the rich neighborhood of the West Island, you have a 10-year difference in life expectancy together with the downtown Montreal. I'm not going to be making any editorial comment about where were the Liberal votes and the PQ votes and the Québec Solidaire votes, and I guess you can figure that out by yourself. But essentially, there is something going on where people live that makes them live either longer or shorter lives. In his report, indeed, the Director of Public Health created what I would call a three-pronged strategy to reduce health inequalities in Montreal. Fairer access to prevention, and we all know that our nice preventive programs do not reach those who are in the more need for them. Advocate for healthy public policy so that other, like the City of Montreal, like public services will have action that are creating different dynamic with regards to the social determinants of health, and supporting intersectoral local action. At the end of the day, we need as well to be with people and help them create the conditions that will mitigate. And we all know that these are mitigation measures. If we would be really serious about it, we would declare war on poverty. But what all we do, essentially, is to try to mitigate this idea that for a reason or another, we're not ready to declare war on poverty. So this idea of the local production of health. So when we started this work, we started by counting resources, with the very naive idea that if you have a low resource, you have lower health. But we realize that resources is not proportional to the health in those local geographies. So what it is, then we started really thinking hard to develop this understanding of what a place is like. And for us, a place is composed of a series of environments that provide resource, but the key there is not the number of resource, but the rules of access to these results. And the rules of access might be are of 4 types do we propose. The first is the physical environment in which the rule of access is proximity. And my own personal problem with all this, this discourse on the built environment is that we're essentially discussing those results. They are absolutely crucial, but they are not the only one. The rules of proximity is that if you live in a polluted environment, you get the pollution. It's as clear as that. So by proximity, you access or not those results, those resources. If you live close to a park, you have access to green space. In those who work in the poverty area know very well that there's also an institutional environment, and that's where it becomes interesting, because in a city like Montreal or in a city like New York, the poorest area are where you have the most density of institutional resources, for a very simple reason. Those people, the only way they can access resources is through their right as a citizens. Take, for example, housing. Housing is a resource essential to create a life. And safe housing in a safe area that doesn't have mold, that is not overcrowded. Okay. If you have enough money, you will access it through the market, through the private sector area. If you do not have enough money, you cannot access it through the market. You will access it through social housing provided by the city. And your entitlement to this housing is to be a citizen, which lives, again, a series of other people outside of it. Refugees, people, illegal people, that are left at the end of the day to a 4th type of environment to access resources is what we call informal reciprocity, where it's your identity, being a refugee or not, being a gay person or not, being a woman or not, being a woman victim of violence or not, that will entitle you to get to those results, to those resources. The reason why you think that in very wealthy neighborhood there is no resource is that essentially because everybody access very high quality level of resource through the private market that's outside and brought by car, brought outside of the local production. So when we started thinking of places in those terms, we wanted to match it with a conception of health that would help us as well make the link. So what is it that makes you, that enables you to transform those resources into health? And a colleague of us at University of Bern in Switzerland, Thomas Habel, has taken those ideas of capitals taken up from French sociologist Pierre Bourdieu. And indeed, for Thomas, health comes from the capacity to use your capitals in an adequate way, in a way that corresponds to the type of resources that you have. Essentially, if you're an immigrant, you usually do not have neither cultural capital. You come from a place where that works in a different way than the place you're in. Your capital that you have, all your education, language, might not even be relevant in your new place. By definition, you do have a limited relationship, limited social capitals, and unless you're one of those rich capital investment immigrant, you're usually lacking some economic capital. You do, however, because of our screening process in Canada, usually have a good biological capital. We rarely let in people who are sick and diseased. So essentially, if you're going to make it here as an immigrant, you're using your biological capital to create a work for yourself in which you're going to work hard, make money, create, and this is this biological capital that you're going to use to create other types of capital. So essentially, then, for us, local health is produced like that, meaning that it is configurations of environment that match or do not match the capitals, the capacity to access those resources and transform them into health that people have locally. So, as a consequence for local action, the first consequence is that living environments are very, very stable. Their transformation through reforms, programs, and policy is a very long process, as anybody who's tried knows it. But we still continue to try. And transformative actions have to take advantage of this recursivity. So essentially, what we're saying, there's no right point of entry, either the people or the environment. Both are point of entry. But what we need to make sure of is that they talk to each other. That as people change and as people gain those capitals, we produce resources that will match those needs. And essentially, that we do not take away resources that correspond to the level of capital. This is probably why, program cuts in social housing are disastrous for many, many, many Canadian families. Essentially because as the market prices of real estate has increased dramatically in Canada over the past 20, 25 years, salaries have not grown to that level. So at the end of the day, if you take away the social housing that is available through the fact that you're a citizen, what you're left with is the community organization, the local people who will get organized together based on some kind of identities. So, given that, and the Make Calgary is a very good example of that. What we call this social health space, which is the translation into the health realm of social reality. When we interpret housing as a health issue, we're creating this social health space. We're creating a space in which health actors come from every trade of life. If your grocery store owner is not just a shop owner on the street, but a provider of health, then you also put health as a political issue. Health become then the ways in which, or a prism through which you will read social reality, but also a result of that social reality. I'll drop that. And just going back to the role of research into that, okay? Because essentially, when the institutions like public health, like cities of Calgary, like cities of Montreal, try to pair up and develop partnerships with community organizations to be closer to people, because at the end of the day, these are the ones that are left behind. And in your next Making Calgary, you will discuss inequities, and you will have essentially to discuss as well who are those giving a voice to those who are left behind, which are usually community organizations. So you have this differential of power there. So essentially in Montreal, what we've observed, when you have this funders-fundee, power from the institution, you create a dynamic which is complementary to action, but with a total orientation towards action. In community organization, people are reactive. Okay, they are solution-oriented, they are action-oriented, they have a huge capacity to innovate. Well, I'm sorry, but even though the best intention, municipal administration, is always remoted to action, there is accountability issue. We cannot just spend money the way we want there, and it's a good thing. So there is a stability there. So the question, and it's a reproductive force. So in our work, what we've observed, and we've written about that, is that the role of research there thickens and depolarizes those two different orientation towards action. Being there as a third party, researcher as a third party, whose work is to report on what's going on, creates a different dynamic in there. And what I would call this social health space, in which research is one of the pillars, brings about this capacity of innovation with a sustainability issue that makes those local inventions more sustainable, which at the end of the day is what we want to achieve. So essentially, what we've discovered and what we've experimented in our daily life as researchers is being out there, not telling people what to do, not giving them the solutions, but studying with them the solutions that they are inventing, developing, telling them as well, giving them as well the navigating clues to those inventions, depolarize this space, makes it even more capable of reflecting on itself and creating innovative solutions that have better chance of being sustainable. So, in conclusion, what we think and what are the main message I would like to leave you with is this social health space is a hybrid space in which health hegemony can be contested. And with my daily work with the Director of Public Health in Montreal, it took a tremendous amount of time for him to realize that the fact that his solutions were contested by the very people he wanted to help was a good sign. And it was a sign that those solutions cannot come from the top, neither a municipal organization nor a research organization, but it takes the buy-in of people. This social health space is a political, it's where things are discussed, and knowledge acquires a very, very strategic meaning in that. And as researchers, we are tempted to take a high stance in the action. And I see researchers a little bit like journalists, in the sense that we are witness. But as journalists, we tell people what's happening, but contrary to journalists, our role is really to link what's happening here to a broader body of knowledge, and to create linkages between what's happening locally and what others have done, and what are the main lessons we can drive from all that. Essentially, what I've just described is participatory and intervention research that contributes indeed to regulate this political space that is created when institutions and people get together and try to work together to locally invent a better life for themselves. Thank you very much. I will take questions.
Is there a question or two?
Between you and the break?
In back.
No, no, and I don't need to be, but the work we've done is embedded in a chair, and the chair is embedded in the Léa Robach Center for Research on Health Inequalities in Montreal. So it's not individuals that do that. It's organizations, and as research organizations, we do that kind of research with students, with community organizations, with decision makers from the City of Montreal, from the public health organization. So I'm just, the spokesperson for a much profound and I would say much more rooted organization. I have tons of practical examples. An idea about that, and when you start telling people what they do, you start understanding why things are not the way they are in textbooks. Okay, so in textbooks, we think that, we have a plan, we implement a plan, we evaluation a plan. If it's good, if it's good, then it gets sustained. If it's not good, then it gets discarded. It doesn't work like that. So what we spend about 6 years and 2 CIHR grant and 1 SSHRC grant following the development and accompanying the development of school kitchen program, okay? And a PhD student worked on that, and in public health, a PhD student in education as well. So essentially that was, and we published the genealogy of that program. So it was trying in poor neighborhood of Montreal to develop kitchen classes, but that was totally integrated within the curriculum of primary school. and that was implemented in 8 schools, funded by a charity. So, and these people were having problems trying first. They were not educators, so we brought educators, we stabilized the program, we institutionalized what they wanted to do, and to be able for it to be taken up by the Ministry of Health. But indeed, when you take this idea that was supported by goodwill and by mothers and by nutritionists ingrained in the community, and you try to scale that up to a province, it's not sustainable. So what are the transformation that goes into that? So even though you have a very positive evaluation, so it doesn't work that way, okay? So what I was saying is that the world of action itself does not get into the world of reproduction that is the institution easily, okay? And you need some lubricant in there. And knowledge is one of the lubricant, but it's never taken up as is because there are many competing interests there. So it's one of the, for young people who are entering this world of research and intervention research, thinking that, well, we're going to change the world. Yes, we're going to change the world. But collectively, with the accumulation of many, many, many projects, and a single project has rarely changed the world. Hope I answered.
Can we do one more? Are you okay with that, all of you? One more question.
Getting back to your graph about the differences in life expectancies in different parts of Montreal.
Yeah.
Have you, as a researcher, done any work with people living in those different spaces to figure out what can be done to reduce those differences?
Actually, people figure out what can be done for themselves. Okay, and actually, the project that we're working on, actually, we have deployed observatory apparatus in 4 poor neighborhoods of Montreal, following 8 projects in real time. So one of the problems when doing that kind of research is that we're doing it retrospectively, so people have to tell us what happened. What we're doing now, we're having those social observatory and we're documenting what's happening in real time. So nonetheless to say, we're capturing a lot of noise, and it's very resource intensive because we're capturing a lot of noise, and as action unfolds, we don't know where it's going to lead us. So and there's not that many such projects going on. It's very risky research. We don't know what we know that we're going to be able to produce a lot of methodological papers on how to do that, what are the pitfalls, and blah, blah, blah. We have a few students doing masters and PhDs on those projects, and so this is only 2 years old, but just to give you an idea, it took us a year to choose the projects and select the neighborhoods. So it's a research that takes a lot of time, and we are producing an enormous amount of data that eventually we'll be able to make sense of. But yes, we're in the field, but we're trying to make sense of what people do instead of doing projects with them.
Thank you. I think that's a really striking example of why discussions like this are so important, because we begin to understand more clearly on how we all share so many objectives that we come at through our own particular areas of expertise in different ways, but always with that shared goal. So I think that that is fantastic for us. So on that, please join me in thanking Dr. Louise Potvin. And I love the fact that you're all so engaged, but we are thus a little bit late for our break. But why don't we come back here at about 11:05, please? And there are drinks at the back of the room and snacks in the lobby. Thank you.